Thank you. Okay. So I'm speaking against the motion. Greetings from the place where I work, DMCNH. So as an anesthesiologist, when the patient does not breathe, nothing else matters. I think everybody in this hall recognizes this. Airway management is really easy, but except when it isn't. I think all of us have faced these kind of problems in our day-to-day clinical practice. And it can be difficult to oxygenate, ventilate, intubate, and in difficult situations, even perform a cricothyroidotomy. So the options are different. If you have planned in advance for a difficult airway, you can't get the airway, you can awaken the patient, regroup, go for coffee. But if you embark on the way for a regional anesthetic technique and then you can't get an airway once your block has failed, what do? It's written over here. So what is difficult airway? I don't have to tell the esteemed audience over here what is difficult airway. We all know what it is. And then when I went through the net, there was a book which was available. We always talk of evidence-based practice of anesthesiology. And do we have any evidence on it? Not much, because for the majority of patients, the airway assessment can be done with a brief systemic history, physical examination, and it does not require additional diagnostic evaluation. There is no evidence, no randomized controlled trial yet, and the desire to avoid publication of adverse events and the relative infrequencies of lost airways combine to make the literature on this topic very less. However, to emphasize, the endpoint of greatest importance when comparing regional versus general anesthesia for a patient with anticipated difficult airway would be patient mortality, and we do not want patient mortality over here. ASA guidelines are familiar with everybody. I'm not going to go through this. So at first sight, regional anesthesia or local anesthesia, it appears to be an ideal solution to a patient with difficult airway. But the problem has not been solved, it has only been avoided. According to me, it is a good idea to start a superficial surgery with a local anesthetic. If you can stop the surgery at any point of time, or you can abandon the surgery, you have a good access to the airway, you have taken an awake intubation consent, and you are not going to give any sedation to the patient, then it is a good choice for doing surgery under local or regional. However, it is a very bad idea if you start with a gallbladder surgery with a thigh spinal in a difficult airway. You're going to lead yourself into a problem. Binovov, Dr. Sandeep has already said about this. He says that regional anesthesia in a patient with known difficult airway requires a high degree of judgment and concludes that it is unacceptable to do regional anesthesia with a known difficult airway when the surgery cannot be terminated rapidly and there is a pure access to the patient's head. You have to explain to the patient that in case of an unsuccessful block, the regional anesthesia has to be converted to general anesthesia, and you have to tell them the adverse outcomes associated with difficult airway management and general anesthesia. Fat is not a three-letter word. Obesity, I think, is the worst enemy of the anesthesiologist, leading to difficult airway and a difficult regional block. What do we do with these kind of guys? I think we all have faced these kind of situations in our practice, and I don't have to emphasize more. So here comes the role of the anesthesiologist's experience. The anticipated technical difficulties and the success rates are the factors which allow the anesthetist to use a regional anesthesia technique. Failure, Dr. Murphy's law of spinal failure. We have to remember that. And Vincent Chan also says that regional anesthetic techniques have a failure rate up to 20% because of incorrect needle or local anesthetic placements. This is a study in which they have seen that obesity is associated with a higher incidence of failed block and a higher incidence of acute complications. Then we have various technique-related complications. I think most of us have faced this. Inadequate or failed block, total spinal block, patchy block, and not the least, last. Just, this has been mentioned before also, the incidence of failed spinal, you can see it's so high, 17%. And what do they say? It is errors of judgment. errors of judgment don't come in patients with difficult airway. There should be no error there. So what do we do if there is a failed block? Repeat the injection? I don't think so. Manipulation of the patient's posture, supplement with local anesthetic, use of systemic sedation in an already compromised airway, given general anesthesia. Is it safe to turn a breathing patient into an apneic patient, turn a compromised airway into a no airway, and least of not the least, turn a CVCI patient into a can't resuscitate patient? It'll be a horror. And then when we come on to the management-related complications, this all is very familiar with all of us over here. Always have a difficult airway cart. This cannot be overemphasized. And if we come on to the difficult airway logarithm, come on, if it is a recognized difficult airway, why do we want to go towards the regional anesthesia side? Have proper preparation, go in for awake intubation. There are various choices for awake intubation. Why do we want to land up ourselves into a difficult problem? Awake fiber optic is the gold standard, and if suspicious of trouble, awake intubation. If you get into trouble, waken up your patient. Always have a plan B, C immediately available. Plan to go ahead, will to move on, and intubation choices, there are many. Ankylosing spondylitis, he was an MD physician himself. He knew that intubation and spinal was difficult. We did a fiber optic and we were happy. This has been covered by Dr. Sandeep again. One thing I want to emphasize over here, that lateral and prone positions require attention to the airway. You cannot give regional anesthesia to these patients. Then surgery is unpredictable. Prolonged major surgery, blood loss is there, unforeseen surgical complication, unstable hemodynamics. What are you going to do? You have to manage the airway. So optimum anesthesia balance mandates individualized assessment of risk and benefit ratio. So I would like to conclude over here that as anesthesiologists, the decision making is up to you. It is your personal experience and preference. Remember, in a kind of situation, do not use anything fancy which you have never used ever before. And before making the decision, always assess the quality and the kind of equipment, the kind of help, senior help, assistant help you have, and of course, what kind of surgeons you're working with. Thank you very much. After permission from Dr. Bala sir, I would, The Department of Anesthesiology and Critical Care, Dayanand Medical College and Hospital, where I'm working, this is in Ludhiana, Punjab. We are organizing the 4th National Conference of Indian College of Anesthesiologists. This is from 23rd to 25th of November 2012. So you can log on to icacon2012.com. You all are cordially invited for this conference to enjoy the Punjabi hospitality. Thank you very much.